I'm Dr. Joshua Prager, Director of the Center for the Rehabilitation of Pain Syndromes at UCLA Medical Plaza. We have a comprehensive functional rehabilitation program at the CRPS and also perform ketamine infusions for those patients who desire and need them. We've been performing these infusions for approximately 5 years here at the Center for Ambulatory Surgery Treatment, also called CAST, here in Westwood, California, approximately 4 blocks away from the UCLA campus. Today, we are going to witness an infusion for one of my patients who's been receiving periodic ketamine infusions for approximately 4 years. Elizabeth, who you will meet, has CRPS that developed as a result of a foot injury, and while living in Arizona, had multiple therapies, none of which were particularly satisfactory for her. She found that she had multiple untoward side effects to the systemic therapies and did not have substantial pain relief. She had a significant sleep disorder and was extremely distraught without ability to perform normal activities of daily living when she first came here to California. She underwent a comprehensive interdisciplinary functional rehabilitation program that provided marked improvement, although did not give complete remission. Eventually, she underwent a ketamine infusion, which after a single infusion provided her significant pain relief so that she was able to walk on a beach the following day and feel better than she had in many years. She returns to see us when the effect of the ketamine begins to wear off and has learned that if she does it sooner rather than later, she needs less therapy and gets a more profound effect from even a single infusion. She's here today after approximately 12 weeks since her last infusion, here for ketamine to put her back into remission. She has high expectations. I hope you enjoy meeting her.
I've had complex regional pain syndrome for 10 years, starting in May of 2000.
And what caused it originally?
Originally, it was a broken sesamoid that I suffered during a car accident. It wasn't caught during the original x-rays that were taken, but 2 years later, my foot rebroke, and after the cast was taken off 8 weeks later, my doctor immediately noticed the symptoms had already onset. There was swelling in my foot, discoloration of my skin. The texture had begun to turn shiny in places, and it looked as though the skin was thinning, and my foot had actually atrophied to the point where I lost full shoe size. The pain in my foot was burning. Sometimes the burning was so intense that my foot would actually blister. I began physical therapy to treat the RSD. We wanted to keep it contained to the foot, but due to some outside influences, I wound up spreading to my left foot and up both legs. There were times when my right leg has turned completely purple and my left leg has stayed completely white, and times when the color will actually jump to my other leg and start at the area closest to my right leg and then actually move across till the color eventually consumes my left leg as well. I slept with ice packs and beach towels under one or both legs for 5 full years. Well, the life I had before the onset of the RSD no longer existed. I lost the ability to ski, I lost the ability to drive long distances. The different medications that the doctors were trying were either ineffective or they made me nauseous, caused fainting spells, and left me feeling very groggy. It was a terrifying and frustrating feeling not to be able to gauge the level of my own lucidity, and I really felt like I was losing control of my ability to complete abstract thoughts or any sort of complex thought processes. I began to notice changes in my ability to be around loud noises, to be in any room that had bright lights. So I developed a hypersensitivity to even touch, things, everyday activities, things like just taking a shower would feel like pins and needles on my skin. So the life I had before RSD, again, no longer existed. It was 5 years from the onset of the RSD. In 2004, my foot broke again, and I developed hemoarthrosis in my right foot. My toes started to turn purple and then black. We thought I might actually lose some of my toes. No one wanted to put a cast on my foot, so I was walking on crutches. Because of some of the problems I had developed with my depth perception, I tripped going down some stairs Thanksgiving weekend of 2004. But I landed on my crutches and tore some of the brachial plexus nerves across my chest and dislocated my collarbone. At that point, that was when the RSD spread up to my shoulder and basically the right side of my body. A doctor friend of mine came to visit me about 6 months later and had seen the difference and the change in my physical and emotional state, and also went through my medicine cabinet and saw some of the experimental medications that I had been taking, things like epileptic seizure medication, things that he didn't think were helping me, were only hurting me, and he actually was the one that put me in touch with you.
The decision on when to use ketamine infusion therapy is one that is variable according to which patient it is. Many patients now find out about ketamine through reading literature articles or by doing searches on the internet and come in specifically requesting ketamine. Often it may be premature in that a single nerve block or aggressive physical therapy alone would be enough to produce a remission. Early in the progression of CRPS, less aggressive modalities often are highly successful, and that's really dependent upon catching the syndrome early. Once the syndrome has progressed, ketamine becomes a more reasonable therapy for patients. The average patient that comes to see us gets about 3 months from between 1 and 3 infusions, and then returns when pain and CRPS symptoms begin to resume. What patients have indicated is that it's better for them if they come back earlier when the symptoms begin to return rather than waiting for them to become full-blown. As a result of this, often we only need 1 or 2 treatments once the patient has had their initial therapy to get the patient back into remission. This reduces the need for systemic medications, and patients feel much better in terms of their ability to perform activities of daily living and their need to take medications being substantially reduced, if not completely eliminated. The goal of functional rehabilitation in a CRPS patient is to give the patient skills so that they can move on with their lives and return to who they were. There's an old saying that if you teach a woman how to fish, she won't be hungry anymore, but if you just give her a fish dinner, then she won't be hungry that night. And we try to give people the ability to move forward by having insight into their pain and insight into how they can relax in a stressful situation that often can exacerbate complex regional pain syndrome. With regard to the patient that we are seeing today, she actually has done 4 weeks of comprehensive functional rehabilitation and twice has come for 2-week booster sessions to revitalize many of the things that she's learned. We have somebody who had lost all her ability to have normal function, who now cooks for a home where she has multiple teenagers both living there and visiting through her friends, and has quite vital life.
The more ketamine infusions I seem to have, the more effective they've become. They're not losing their effectiveness. If anything, because I've learned to prepare myself properly for them, and because Dr. Prager understands, the right dosage, given how many infusions I'm going to have, whether I'm going to have 1 or 3 in a row, he's managed to gauge it very well and successfully, so that their effectiveness has gotten better. It hasn't worn off. There is, some after effects in the sense that I can feel the ketamine in my system, but the side effects have all been beneficial. I am able to get my sleep cycle turned around again. RSD patients, including myself, tend to have bouts of insomnia. We tend to feel our pain more at night than other times during the day. I sleep better after my ketamine infusions. I have more energy. The amount of pain medicine I need is at the absolute minimal I've ever had to take over the course of the last 10 years. I have more energy, and as long as I manage my activity when I get home, and I try not to do too much to make up for lost productivity, I have nothing but positive benefits. So.
Can you tell us a little bit about what the experience of undergoing the ketamine itself is like?
When I first underwent a series of infusions, I had visions, and the visions were, there was a current, an underlying current that seemed to run through each vision. The first set involved me witnessing the actual building and development of the LA Basin, and by the day of my last treatment, I was actually having visions of the UCLA building being built, Dr. Prager coming to work, and me coming to LA. Since then, my visions haven't been, they've been more abstract and hard to articulate, but the experiences usually revolve around me working at repairing my body, I'm always trying to fix my RSD in my mind and fix my body, and try to resolve pain in the places that I'm feeling it. So I've never had anything negative. They always center basically around me preparing for and trying to heal myself.
I'd like to make a distinction between the work that we do here and the work that Dr. Schwartzman published in the journal Pain in December 2009. Dr. Schwartzman is clearly a leader in development of many of the complex regional pain syndrome therapies, and in particular has been at the forefront of ketamine therapy since its inception in the treatment of CRPS. Dr. Schwartzman performs double-blind, placebo-controlled, randomized studies under a very strict protocol that does not allow for much flexibility in the doses that are being administered. This is the only way that good research can be produced, and I commend Dr. Schwartzman for the work he's doing. We, on the other hand, are not doing research here on this treatment. We are attempting to provide the best possible therapy and not produce evidence-based data. Thus, we have greater flexibility to provide adjustments in doses based on what the patient needs and how they tolerate what we are administering. Thus, when a patient comes in the first time, they receive doses comparable to what Dr. Schwartzman administers in his protocol, but if the patient tolerates this well, we have the freedom to escalate the dosage using the same protocol in terms of the amount of time. All our patients receive clonidine and an anti-nausea medication as adjuvant prior to receiving midazolam before the ketamine. We've had large dosage ranges for our patients, and I think part of the reason that we have the good results that we have is that we have the freedom to escalate the dosages to much higher than those that would be permitted in a research protocol. We have an interesting way of determining when to induce the ketamine or when to administer the first ketamine. We get the patient to a point of amnesia that they no longer can remember things, whether they are awake or not awake, and we feel that's the appropriate time to administer ketamine. This keeps the patient in a relatively light state, not being truly awake once the ketamine is being administered, but not being very deep, so that as soon as the ketamine infusion is turned off, the patient tends to wake up within minutes. The patient is usually arousable during the infusion, yet we choose not to disturb the patients. Most patients choose to bring music with them that they find to be quite soothing. I want to mention a few words about the adjuvant medications. Because of ketamine's effect on the way patients see initially with large amounts of nystagmus, patients can become nauseated. We therefore administer intravenous anti-nausea medicines prophylactically before administering the ketamine, and then again at the conclusion of the infusion. In addition, as a result of the work that Dr. Olney has performed, all of our patients receive clonidine as a prophylactic medication. Dr. Olney feels that clonidine has a neuroprotective effect in the use of ketamine. None of our patients have had any side effects from the ketamine aside from some occasional nausea and some grogginess the day of the procedure. So we have some monitors on. We have electrocardiogram, which we can see over there, pulse oximeter, which measures the oxygen in your blood, and then we have an automated blood pressure cuff on your calf to measure your blood pressure. So we're measuring your heart rate and your blood pressure and the oxygen in your blood as we do this.
Yes.
Now, so did you sign any special paperwork related to the ketamine this morning before we did this?
Yes, I signed an informed consent document, and I do it before every ketamine infusion.
Okay. Now, we're going to give you 3 different medicines before we actually give you the ketamine. And the first medicine is a pill of clonidine, and so we'll give you that.
Ready? Can you
Yes.
take this off?
And
Got
now
it,
the
Doc?
second medicine is a medicine that prevents nausea, and we give that in an intravenous form.
Goes in your IV, sweetie. You're good.
We've already established an intravenous line. And then the final medicine before the ketamine is the Versed, and we have a little protocol here where we actually start the ketamine after you lose your memory.
Yes.
And you have a particularly, what's your IQ?
Do you really want me to say it on?
Well, you have a high IQ. We'll just leave it like that. And so your memory is about the most extraordinary memory that I've seen. It takes a lot of Versed to make your memory go away, but we make your memory go away before we start the ketamine, and you can still be somewhat awake at that time, but that's all we need to make things smooth, and then we don't give you too much Versed so that you have trouble waking up. We just get you to the point where you don't remember, and we find that that's smooth. Now, you actually have a fairly high Versed requirement. What's that? Yeah. Elizabeth, tell us how you feel. Do you have any pain? What's that?
At the moment,
At the moment, what?
moment.
Yeah.
At the moment,
At the moment,
I have no pain.
I have no pain.
Right.
Well, you're just waking up now.
Gotta go.